Hi everyone, good evening. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. A little about me: I'm Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. I've done my MBBS from Father Muller Medical College, Bangalore, my MD in Anesthesia from Father. Today's topic will be benzodiazepines. I took the first part yesterday. I'll be dealing with the second part today, and I'll run through the first part, so that will be a revision, and then we'll cover the second part. So, a little about Unacademy. It's one of India's largest learning platform, online learning platform, where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. So what will you get out of Unacademy? Basically, we have daily life classes. So when you go, so basically when you I had no clue what it was. So during a coaching class, uh, it's you have to get up, get ready, reach there. It's very difficult for your educator to clear your doubts, because your educator has a stipulated amount of time. He or she has to finish the class within that time. It's difficult for the educator to break the flow when they're talking and to clear each one's doubts. But on Unacademy, you can chat with your educator, engage in discussions, clear your doubts and answer polls, and all this is while the class is going on. Now, all these courses are structured and are in line with your exam syllabus and help you best prepare for it. So basically, your educators have researched and on topics, and whatever is best needed for whatever is best needed for basically whatever is needed for from NEET PG point of view is what is so whatever is needed from NEET PG point of view, we make your syllabus according to that. Now, live tests and quizzes. So we evaluate your performance on a regular basis with our mock tests and quizzes, and this will help you all. Basically, this will give you all a detailed analysis. This will help y'all gives y'all a detailed analysis on your performance, so y'all can gauge your performance and know what is best for, you'll know where y'all stand basically. Then unlimited access. So one subscription gets you access to all our live and recorded courses, and you can watch anything from the and you can watch all this from the comfort of your home. Okay, so now these are some of our top educators. Dr. Nikita Nanwani, she's a NEET PG mentor for radiology as well as mnemonics and concept focusing and must know topics encompassing all subjects. Dr. Mohammad Azam, Dr. Preeti Sharma, and Dr. Devesh Mishra. These are some of our courses offered. As you can see, there are like almost 19 subjects that you all have to cover. I know it's quite difficult. NEET PG is not an easy exam, and we have various courses under each subject. Now, coming to subjects like dermatology, psychiatry, anesthesia, radiology, these were subjects that you all didn't really have to do in detail during your NEET PG, right? During your undergrad. So during undergraduation, during MBBS, you all didn't have to do these in detail level, like, smaller subjects, basically known as the smaller subjects, because you didn't have to go into depth. But these subjects are actually specialty subjects. They're huge. There is a lot to cover under them. And unless you know something about them, these are not subjects where you will be able to answer the MCQs without going through these subjects. But the plus point is, like during MBBS, you all didn't have to go into depth. Even over here, it's not like you all have to know everything about the subject. Basically, you all just need to know the basics of these subjects. because the questions asked to you all also will be from the basics. But with your anatomy, physiology and all, they are awarded 44 marks. They have a lot of marks allotted to them in the NEET PG. So in those subjects you have to go in depth, because you have spent a year going through those subjects basically in MBBS. They can ask you anything from anywhere, but generally from dermatology, anesthesia and all that, it is generally stuff that if you have gone through anesthesia and at least revised it once, you will definitely be able to answer. These are some of the ongoing courses on our platform. So we have a course on neurophysiology, course on GI surgery, cardiovascular thoracic surgery, course on larynx, respiratory system, course on pathology. So coming to the NEET PG subscription, there are 5 types of subscriptions as you all can see on your screen. And those of you who are giving NEET PG this year, your 6 months should be okay. But for the rest of you, if you all want to like take a little more time off, I will highly recommend the 12 and the 24 months. Don't worry about the time. Nobody is going to ask you at the end of it, how long did you take to clear NEET PG, or how long did you take before you got into your post-graduation. Nobody will ask you such questions, because once you're a postgraduate, it's just about you finishing and starting practice. Nobody is going to ask you how long you took to become a postgraduate, because that's not what it is about. Basically, medicine is all about practice, and once you choose your specialty, finish specializing in it, it's practice from there. So that's all that matters. Also, it is more economical. So it's a one-time subscription on Unacademy. So after 6 months, you will have to subscribe again if you want to access the quizzes or the classes or anything. You'll have to access again. So it's just a one-time subscription. So your 12 month, 24 months, at least you have the buffer period. Then again, when you come to the subjects, so this, at least this 1 and 2 years will, if you all are planning to drop, it will at least give you all insight into which subject you really want. Because in undergrad you're doing subjects per year, so you develop a liking, because as the years progress, trust me, it gets more interesting. From anatomy to medicine, obviously it will get more interesting. I mean, usually it gets more interesting for most people. Nothing wrong with anatomy and all that, trust me, but I'm just saying that, that's how the mentality is. But we are not exposed to the subjects like dermatology, radiology and all, so we don't really know. And then it's more social stigma, oh, take radiology and all that. But at the end of the day, you have to enjoy what you're doing, right? It's your profession. It's what you are going to be doing for the rest of your life. You need to enjoy it. So for that, this time actually helps you, because while studying you can actually choose your subject, and that's when you realize, oh, I kind of like this. Maybe I should not take maybe I shouldn't take orthopedics. Maybe I should take dermatology, vice versa. Maybe dermatology is not for me. Maybe I should just take medicine. I enjoy medicine more. So it actually gives you time to focus, even though there is no practical thing happening during that time. So please use my code SASHA. You can avail a 10% discount. As you can see, these are all the discounts over here. The 10% discounts apply to all. So as you can see, this is a 12-month and this is your 10% discount. Again, this is the 24 months. Sorry. The 24 months. And this is your 10% discount. So I'll just briefly run through yesterday's class and then we can proceed. So yesterday we did the general properties of benzodiazepines. So benzodiazepines are basically compounds with sedative. So they have sedative, anxiolytic and anticonvulsant properties. And as the dose is increased, so the first property is anxiolytic, which is followed by sedation. The dose response curves are comparatively flatter as compared to barbiturates, so benzodiazepines are safer. First clinically used benzodiazepine was chlordiazepoxide. This is not needed. This is the classification: long-acting, short-acting. Your short-acting is midazolam, long-acting is like diazepam, nitrazepam, flunitrazepam. Potency and pharmacokinetics. Basically, your longer acting drugs like nitrazepam, flurazepam, diazepam, chlordiazepoxide. So they have a long plasma half-life of about 10 hours. This is because of the active metabolites. The metabolites which they produce are as active as the parent drug, and they add on to the half-life of the parent drug, which leads to the duration of, the half-life being around 10 hours. So hence for this reason, the drugs are not regarded as suitable for long-term treatments. Okay, the benzodiazepines are generally given oral, but they can be given intravenous and intramuscularly too. Now coming to the potency and pharmacokinetics, gut absorption is reliable but slow. These drugs are highly bound to plasma protein, but even though they are highly bound to plasma protein, they do not displace other drugs, etc., from these proteins, and hence do not cause much change in reactions. Diazepam is 96% diazepam is most bound among all the drugs to plasma proteins, mainly albumin. Then these drugs have a large volume of distribution because all these drugs are highly, and these drugs have a large volume of a large apparent volume of distribution because all these drugs are highly lipid soluble. Except midazolam and chlordiazepoxide, these two compounds are not lipid soluble, they are water soluble, though midazolam at physiological pH is lipid soluble, and at pH less than physiological pH it is water soluble. Now because these drugs are water soluble, they can cross the blood-brain barrier and the placental membrane. So like I said, when pH is 6, midazolam is freely soluble, but at physiological pH, the ring structure closes and the drug becomes lipid soluble and hence can penetrate blood-brain barrier. So in general, benzodiazepines are lipid soluble drugs that are not excreted extensively in urine, not extensively excreted unchanged in urine. Basically, they undergo metabolism, and then they undergo metabolism in the liver, and then they excrete it in the urine. So like I said, they are eliminated from the body by hepatic metabolism, and finally through the urine. So there is one basic ring structure modification of which has produced the various types of benzodiazepines, and the desmethyl-diazepam is a metabolite from ketozolam, midazolam, diazepam, chlorazepate, and this is the active metabolite which has a half-life of 72 hours. Thus it converts effective action of these drugs into longer acting. Like I said, though they are extensively bound to proteins, it is a free drug which diffuses across membranes. So benzodiazepines can cross the placenta, and they bind with more affinity. The drug is the amount of drug that crosses is actually it builds up more in the fetus than in the mother. So after giving a mother a particular dose, more amount will be found in the fetus than in the mother because it crosses the blood placental barrier, and it can cause neonatal depression. Hence, benzodiazepine is not given in pregnant patients. There are 3 types of benzodiazepine receptors. The first 2 types are found in the CNS, and the third one is also found in the central nervous system as well as the kidney, heart, and some elements in the blood. So the benzodiazepine receptors are distributed unevenly within the CNS. However, more density is found in the cerebral cortex and limbic system, moderate amount of density in the cerebellar cortex, and low density in the brainstem and spinal cord. Then central type benzodiazepine receptors. So basically there are 2 types. The first 2 types, benzodiazepine 1 and benzodiazepine 2. The benzodiazepine 1 receptor is responsible for the anxiolytic action. Now benzodiazepines basically potentiate the action of GABA. There are 2 types of GABA receptors, GABA A and GABA B. GABA is a pentameric structure, pentameric transport. It's basically a cylindrical channel which is pentameric structure, 1 gamma, 2 alpha and 2 beta subunits. It potentiates the action of GABA by causing increased chloride conductance, hyperpolarization, and thus blockade of action potential. The highest amount of GABA receptors are found in the cerebellum, hippocampus, hypothalamus, basal ganglia, and in the spinal cord in the substantia gelatinosa. Okay, so this is how GABA acts, what we discussed. So GABA basically, the GABA interneurons act on the primary afferent nerve fibers and prevent the release of nerve transmitter and action potential generation. Now the anxiolytic effects of GABA, basically the anxiolytic effects that is produced by benzodiazepine is due to the potentiation of GABA. Anticonvulsant effects of benzodiazepine. So many conventional, basically the GABA has a role to play in the anticonvulsant effect. That is what this is about. So many anticonvulsants act through GABA and bring about the anticonvulsant effect. So like I said, benzodiazepines basically potentiate the action of GABA in the various places in the central nervous system. Yeah, this is the same thing. So peripheral type benzodiazepine receptors, they are located, they are not coupled with GABA receptors, but they are located peripherally in the kidney, blood, and heart, and they have been well recognized now. Endogenous benzodiazepines. So like endogenous opioids, there are endogenous benzodiazepines too, and maybe the beta CCBs and endogenous agonist at the benzodiazepine receptors. They act by controlling GABA neurotransmission. Now, advantages of benzodiazepines over barbiturates. So benzodiazepines have a high therapeutic index. So ingestion of hypnotic doses does not endanger life. So if in ingestion of even 50 hypnotic doses of benzodiazepines, the patient can still be awoken, right? There is no effect on cardiovascular function. They are very cardiostable. A slight fall in BP may be seen in the case of diazepam and LORAZEPAM. It is because of decrease in cardiac output, whereas in the case of flunitrazepam and midazolam, it is because of the decrease in the peripheral vascular resistance. So benzodiazepines basically cause least distortion of the sleep architecture. However, depending on the drug which is used, there can be some, depending on the drug that is used, there can be some hangover effects. So the longer acting drugs can produce a feeling of, not waking up fresh, because these longer, basically benzodiazepine interfere with REM sleep pattern. So the longer acting drugs will continue to interfere with REM sleep pattern, so the patient does not awake fresh. But the shorter acting benzodiazepines, they bring about the hypnotic sedative effect, and then they wear off and the patient continues to sleep through the night and gets up refreshed. Okay, they have lower abuse liability, tolerance, withdrawal, dependence, psychological dependencies, all mild as compared to barbiturates. Specific benzodiazepine antagonists. Antagonist flumazenil is known. Yeah, this is very important. So it has an antagonist, whereas benzodiazepines do not have, barbiturates do not have. Now, various action of benzodiazepines: anxiety, anxiolytic, sedation. As the dose of anxiety increase, with lowest doses, anxiety is produced. As the dose is increased, it leads to sedation and hypnosis. It has also been used as inducing agents. Cardiovascular, basically they're not very good for inducing agents, but it can be substituted with other agents. They potentiate the action of other induction agents. So anticonvulsant, like most, they have anticonvulsant property, we discussed about it. Muscle relaxant, because it reduces anxiolysis, so automatically spasm gets relieved. Basically muscle relaxation. Amnesia, it produces antigrade amnesia. For midazolam, it is 20 to 30 minutes, whereas with longer acting, it can be up to 6 hours, like for LORAZEPAM. So pharmacokinetics, short acting benzodiazepines can be given intravenously or intramuscularly. The longer ones are usually given orally. So have a long-acting have a slower onset of action, therefore oral is preferred. So modest doses, once or twice daily, they provide sustained relief from persistent symptoms. So basically, benzodiazepines are metabolized by the liver, and like I said, the metabolites are as active as the parent drug, and the phase 1 metabolites are excreted in urine as glucuronide conjugates. Adverse effects are it can cause dizziness, vertigo, disorientation, amnesia, increased reaction time and motor incoordination, weakness, blurring of vision, dry mouth, urinary incontinence, irritability, sweating, all these can occur. There are a number of psychological effects that may accompany the use of benzodiazepines in insomnia. Like I said, this is where the REM sleep pattern comes into play. So the longer acting continue to have an effect of the REM on the REM sleep pattern, and the patient wakes up with a hangover. So benzodiazepines can synergize with alcohol and cause excessive CNS depression. Drug interactions due to displacement from protein binding or microsomal enzyme induction are not significant. And cimetidine, isoniazid and OCPs retard benzodiazepine metabolism. So it is used as a hypnotic, anxiolytic, anticonvulsant, central muscle relaxant, pre-anesthetic medication in alcohol withdrawal and dependence, and along with analgesics. Now we'll continue with today's class. Coming to the individual drugs. So diazepam, physical structure is it is insoluble in water. So it is insoluble in water. Solutions for injection contain several organic solvents to make it soluble, namely propylene glycol, ethanol, and sodium benzoate and benzoic acid. These are all to make it soluble. Okay. It should not be mixed with other drugs because it precipitates. So diazepam is a benzodiazepine which is a potent, basically it is a, So it is a potent tranquilizer, muscle relaxant and anticonvulsant. Okay. These properties are due to its effect on the ascending reticular activating system and spinal interneurons, as well as because effect on the limbic system. So it has more effect on this, and hence it reduces its action. It can be given in doses that cause a state of extreme drowsiness, but in which the patient is still, so it can cause extreme drowsiness. So it can cause extreme drowsiness, but it can be given in dose, but the patient is still very arousable. So that is why it is so safe. This indicates its safety profile. So uh, even though it can be given in doses which cause extreme drowsiness, the patient is still arousable. So when it is combined with other drugs as a pre-medication, the incidence of amnesia is increased. Basically, when it is combined with other drugs which also cause sedation, so the incidence of amnesia will also be increased. So along with other potentiating drugs, good amnesia can be achieved. This is very important. Pre-medication in the sense basically prior to surgery. So this is very important because you need to relax the patient before surgery. It has to be as pleasant as possible, the experience for the patient. So on the respiratory system, intravenous injection of 0.14 mg per kg depresses the sensitivity of the respiratory center. IV injection of 0.2 milligram per kg at the rate of 10 mg per minute. The only significant change is tachycardia, which may persist for some time. So basically, it is very cardio stable. Respiratory system, it can cause a respiratory depression because it decreases the sensitivity of the respiratory center. Like I said, no effect on cardiac output. And even if diazepam causes a decrease in blood pressure, what did we discuss? It is because of decrease in cardiac output. So what are the indications for use of uh, diazepam? So it is used as a pre-medicant. It is used to induce anesthesia. So pre-medication basically to relax the patient prior to surgery. Then to induce anesthesia, so as an along with other induction agents. Then it is used intravenously in subanesthetic doses as a so basically for sedation. So in dental, in patients who are very anxious and all during the dental procedure, and basic in the ICU basically for sedation again. So infusions are started of benzodiazepine, generally midazolam, because it is short acting, and we needed to move out of the system quickly when the sedation stopped. We need the drug to be cleared from the system quickly. So for sedation in the ICU, they are put on infusions of these drugs especially when the patients are paralyzed, right? You need to sedate a patient when the patient is paralyzed in the ICU. It's not ethical to paralyze a patient without sedation. It can be used as a sole agent for cardioversion, again only as a sedative during carotid angiography, and orally in treatment of psychosomatic ailments. So it can reduce fasciculations after giving succinylcholine. It can be used in radiodiagnostic procedure for pediatric patients, again sedation. Over here, so it reduces hallucination. So ketamine is basically an induction agent, and the side effect of ketamine is it causes emergence delirium. It causes dissociative anesthesia which leads to emergence delirium. So the patient gets up, has very bad can have very bad hallucinations and dreams and all that, right? So scary dreams and all that. So to decrease that, benzodiazepines are said to decrease this hallucination and emergence delirium of ketamine, and the benzodiazepine of choice is midazolam. Okay, so it reduces dose requirements of muscle relaxants because it potentiates the action of muscle relaxants. So further dosing needed will be lesser. It is used to treat tachycardia, systolic hypertension, anxiety, neurosis. So tachycardia, hypertension because of anxiety can be treated by this, and it is used as an anticonvulsant in status epilepticus, eclampsia, and tetanus. So dosages and administration can be given in the tablet form, syrup and IV. Pre-medication 10 to 20 mg, 1 to 1.5 hours before the operation. For sedation 0 to 2 mg per kg. Total unconsciousness 0.6 and tetanus treatment 5 mg per kg per 24-hour infusion. So basically precautions are consumption of alcohol should be avoided by this patient because it stimulates the CNS depressant effect. Along with alcohol, it exasperates it. It cannot be diluted. It precipitates when mixed with other agents, and it is painful when injected. Coming to midazolam, it is a water-soluble benzodiazepine whose solubility is pH dependent. Right? So we discussed that. At pH below 6, it is water-soluble and forms a stable solution. At body pH, it is highly lipophilic and is rapidly redistributed after intravenous injection. So, MAO inhibitors, mechanism of action is it interferes with the reuptake of GABA, thereby causing accumulation of GABA, and that's how it potentiates the effect of GABA. Elimination half-life is 2 to 3 hours. It is entirely metabolized by the liver, less than 1% excreted unchanged in the urine. Now coming to the CNS, the pharmacology, CNS, its actions are qualitatively similar. So it's similar to other benzodiazepines, and when given IV, it varies from, so depending on the dose, when given intravenously, so midazolam can be given intravenously because it is short acting. So when it is given intravenously, it varies from mild sedation to full GA depending on the dosage used, right? And the drug is highly protein bound, and slight variation in plasma concentration can have a marked influence on the free drug level in the plasma. Then we have on the CVS, it is very cardiostable, and if at all there is a fall in BP that is occurring, if at all it is because of midazolam, it causes a decrease in BP because of the decrease in peripheral vascular resistance, right? But cardiac output changes very little. In a healthy patient, doses of 0.0575 milligram per kg produce a transitory depression of the CNS. So it has largely replaced benzodiazepines in. It has largely replaced not benzodiazepines. I'm sorry. It has largely replaced. Uh, it has basically. It has largely replaced diazepam actually in anesthetic practice, and to produce sedation in unpleasant procedures. So it is basically short acting and very effective. It's not that short acting also that you have to give a repeat dose, but it is not as long. So diazepam can, the mechanism of action is almost 22 hours or so. So this drug is at least, the duration of action is at least for 2 hours. So within that time, the patient does come out, and procedure can be over too. So hence it is used for sedation in short procedures, unpleasant procedures like your endoscopy, CT, MRI, bronchoscopy, any dental work, yeah, under local anesthesia, any work that is carried out. So basically, to sedate the patient before giving anesthesia, this can be used. So when used as sedation, frequently combined with small doses of fentanyl and other opioids. So basically it potentiates the action of opioids, and opioids also potentiate its action. So it is used in combination, and of course this we have discussed, used for induction of anesthesia. So basically for cardiac anesthesia, where we cannot give an induction agent because these induction agents are known to cause a lot of hemodynamic fluctuations because they have an effect on the BP and all. So since we cannot give induction agents in cardiac surgeries, high doses of fentanyl and midazolam are used. So along with the opioids, midazolam is used for induction in these patients. Then co-induction. So combination of sedative drugs with intravenous anesthetic agents have a synergistic action. So basically, any sedative agent given with these with other intravenous anesthetic, it produces a similar effect and causes depression of the cardiovascular as well as the respiratory system. So uh, that's what the synergistic, this basically indicates the synergistic action between propofol and midazolam. So dose and administration. IM dose of 0.078 to 0.08 milligram per kg. For conscious sedation, this is the dose, and it is available for injection either in 1 ml ampules at concentration of 5 mg per ml, or 5 ml ampoules containing 1 mg of. Adverse reactions are disadvantage. It has a disadvantage of cardiogenicity and immunogenicity. It is not cannot be used in lactation mothers and extremes of age. Again, extremes of age, it can cause severe respiratory depression. It potentiates the effects of narcotic analgesic, hypotensive effects of beta blockers, diuretics like calcium channel blockers, magnesium sulfate, and nitrate. So it potentiates the action. Pain during injection, phlebitis, drowsiness, bronchospasm, impaired coordination, and diminished reflexes may be seen. Coming to lorazepam, it is long-acting, generally used in psychiatric patients to calm them down. So it is insoluble in water, basically lipid soluble, crosses the blood-brain barrier. It is dissolved in polyethylene glycol and propylene glycol. It is very similar to diazepam and produces anterograde amnesia and no properties. So benzodiazepines basically have no analgesic properties. So lorazepam produces an increased ventilatory response to carbon dioxide, resulting in stimulation of respiration. There is no marked change in BP, peripheral resistance, or systemic vascular resistance. It has muscle relaxing property, probably due to central urine. So absorption, orally administered lorazepam is rapidly absorbed, and 80% of the dose is recovered in urine as glucuronide. This is important. So indications are basically lorazepam is used for sedation, relief of anxiety, post-op abolition of emergency reactions, and giving IV. But the drug of choice for abolishing those post-op reactions is basically nilorazepam. So dosage is intermediate duration of action, 5 times as diazepam. To relieve anxiety, 1 to 3 milligram is given, and doses up to 5 mg orally or IV are used as pre-anesthetic medication. Like all the others, it potentiates the effects of other CNS depressants, especially like alcohol. And IV injection can produce pain on injection, and long-term use, a high incidence of dependence and withdrawal symptoms is seen with this drug. Nitrazepam, it has hypnotic action and same as diazepam. It is less soluble in water. Just a sec. Yeah. So it has a hypnotic action and same as diazepam. It is less soluble in water. It is used for night sedation and it is used for sedation and pre-medication. It is given, so basically it is used in the psychiatry patients. It's long acting. It is basically used for sedation and pre-medication. Given in doses of 5 to 10 mg orally, and action lasts 6 to 8 hours. Contraindicated in COPD. Now coming to tranquilizers. CHLORPROMAZINE. So chlorpromazine, it is a 3-ring structure which is linked by sulfur and nitrogen, and it is greenish white crystalline powder with a slightly pungent odor. The pungent odor is because of sulfur, and it is greenish white crystalline powder, water soluble, 5% solution has pH of 4.5. So this chlorpromazine contains sulfur. So the pharmacological actions, it depresses the hypothalamus, mesodiencephalic neurons, the central vomiting center, hence it decreases vomiting, stimulation of epileptiform foci. That's how it depresses the stimulation of the epileptiform foci, and then hence it is used as anticonvulsant. It controls the basic metabolic rate. It decreases secretion of the anti-pituitary gland, decreases body temperature, vasomotor tone. The dosage of CNS depressants, hypnotics and analgesics, alcohol and IV anesthetic agents. Basically, it has a synergistic action, so it depresses all. So it decreases the dose of all these drugs. It produces sleep and wakefulness, drowsiness, there's loss of interest, and euphoria are produced by this drug. On the autonomic nervous system, it has alpha adrenergic blocking effect. There is moderate inhibition of actions on ACH and serotonin. There is CNS depressant action on hypothalamic center, which controls sympathetic activity more than basically the central depressant action on the hypothalamic center, controlling sympathetic activity. It depresses it more than postural, causes postural hypertension and tachycardia. So it depresses the sympathetic activity, causes postural tension, hypotension, which leads to tachycardia. So it has an alpha adrenergic blocking effect. So in the CVS, it causes dilatation of peripheral blood vessels, increase in the coronary blood flow, and increase in the contractile force of the heart, and decrease in irritability. So it increases the contractile force of the heart and decreases irritability. It increases the respiratory rate, increases the tidal volume and circulation, and stimulates respiration as a whole. Liver, it increases the viscosity of bile. The viscosity of bile is increased, leads to stasis and intrahepatic canalicular obstruction. So this can lead to intrahepatic canalicular obstruction. Then sodium and water excretion is sodium and water excretion is slightly increased, and there is reversible inhibition of cellular activity, in decrease in the DMR and decrease in secretion of endocrine glands. So basically, everything is reversed because there is reversible inhibition of cellular activity, decrease in DMR, decrease in sodium and water excretion. Sodium and water is slightly increased. There can be stasis of bile and intrahepatic canalicular obstruction. So it depresses the central temperature regulating center and hence prevents shivering. Right? So this drug basically prevents shivering. It increases the effects of both it has a basically potentiates the effects it potentiates the effects of depolarizing and muscle relaxants. It produces sedation, and it can be used as a local analgesic, and the dosage is 2 to 3 milligram per kg, IV bar, IM bar, oral. Absorption, fate, and excretion. So it is well absorbed in oral and parenteral doses. It is distributed in all body tissues with high concentration in the liver, lungs, and adrenal. This is distributed all over the body. It is metabolized. It is distributed all over the body, metabolized in liver by hydroxylation and glucuronide conjugation, and metabolites are absorbed in urine for 6 to 12 hours. So again, metabolized in the liver, excreted in urine. So it is used in treatment of psychosis, schizophrenia, anti-emetic and anti-hiccup, induction of hypothermia, treatment of eclampsia, and basically it's part of the lytic cocktail regime. So it's part of the lytic cocktail regime. The treatment of intractable pain as a pre-anesthetic medication, and anti-rigidity agent in tetanus. Adverse reactions and adverse reaction and complications. So it can cause nasal stuffiness, dryness of mouth, and sometimes palpitations. Intolerance, there can be skin eruptions and photophobia. In the autonomic nervous system, it can cause anticholinergic action, blurring of vision, tachycardia, constipation, and paralytic ileus. The metapoietic system and liver, agranulocytosis can be seen. This is important. Drug can cause agranulocytosis. There are very few drugs that do this agranulocytosis. It causes agranulocytosis, rarely thrombocytopenia, aplastic. So the adverse reactions and complications. In the central nervous system, more than 10 to 40% show extrapyramidal symptoms such as Parkinsonism. Behavioral actions like drowsiness, restlessness, tremors, muscle rigidity, excessive salivation, akinesia, and it may produce seizure. So this extrapyramidal symptoms is very important. It is one of the side effects of these tranquilizers. Causes drowsiness, excess salivation, akinesia. So endocrine and metabolic disturbances, it can cause gynecomastia, lactational and menstrual irregularities. There is a chance of increasing the diabetes, impotence, weight gain due to increased food intake, and of course interaction with other drugs. Basically prolonged with analgesics and anesthetic agents, it potentiates the effect and can prolong the effect. Basically can produce a deeper block, and it is incompatible with MAO inhibitors. Now coming to promethazine, Coming to promethazine, it is a synthetic agent of phenylpyridine group. It is a marked sedative and antihistamine property. It is a potent depressor of upper respiratory tract reflexes, reticular activating system, and hypothalamus. It potentiates the effect of sedatives, hypnotics, anesthetics, and narcotic. So it has a potentiating effect. It reduces the incidence of PONV due to its action of CTZ. So PONV is reduced. It has antihistamine property. Promethazine, remember, has local anesthetic property too. Uses pre-medication to treat allergic episodes because of the antihistamine property, to treat motion sickness, and the dosage is 25 to 50 mg bolus of 1 milligram per kg. So the motion sickness is because of the effect on the PONV, due to its effect on the CTZ and PONV. So trimeperazine. So promethazine is actually used one of the drugs used for treatment of motion sickness. So phenothiazine derivative. Trimeperazine is a phenothiazine derivative. It is a potent central sedative. Again, antihistaminic property, emetic, spasmolytic, and antipyretic. Has less anticholinergic. It has basically no CVS action. Uses move for antipruritic, move as an antipruritic and sedative. So antipruritic again because it is the antihistaminic property. Okay. Dosage is more than 1 to 1.5 milligram per kg. Trifluopromazine is a phenothiazine derivative, marked antiemetic and sedative property. Intensifies and prolongs the action of barbiturates, narcotic, analgesic, and anesthetic agents. Causes hypotension, dryness of mouth. Uses basically as a pre-medicant and antiemetic. So basically, all these tranquilizers are used as pre-medicant, antiemetic. It enhances the sedative, the action of barbiturates, narcotic, and analgesics, and of course, these drugs by themselves have sedative action. Trifluopromazine. It is a potent sedative and antiemetic. Promazine. Dosage is 20 to 40 mg parenterally. Promazine is one-third as potent as chlorpromazine, and dosage is more than 25 to 50 mg parenteral. Prochlorperazine, widely used as an antiemetic and sometimes used in the treatment of migraine and psychiatric disorders. Dosage is 0.2 milligram per kg. Haloperidol. It is valuable in patients with delirium. Mechanism of action is on the B2 dopamine receptors. It blocks beta-adrenergic and histamine receptors too. Per oral, it is given as 0.5 to 5 mg per kg, maximum of 100 mg per day. Peak is within 3 to 6 hours. T-half is 70 hours. So it is a very long lasting. Iron 5 milligram HRD. Peak is 10 to 20 minutes. T-half is 70 minutes. So that is with iron, and with per oral, T-half is also 70. So severe toxic CNS depression, comatose states, and Parkinsonism disease causes extrapyramidal symptoms. Hence, Parkinsonism-like disease can occur. Neuroleptic malignant syndrome, seizures, tachycardia, agranulocytosis. These side effects of haloperidol are very important. So droperidol is basically butyphenol. It is a fluorinated derivative of so it is a fluorinated derivative of phenothiazines. It is a butyphenol over here. The fluorinated derivative of phenothiazine is your droperidol. It is a butyphenol. It is biotransformed in liver into primary metabolites. Clearance is 14 ml per kg per minute. Elimination is around 1.5 to 2 hours. So coming to the pharmacology of droperidol, it is a potent cerebral vasoconstrictor, produces 40% reduction in cerebral blood flow, decreases the cerebral blood flow because of the vasoconstriction. No significant change in cerebral metabolic rate of oxygen. So there is no metabolic change in the brain happening, but it produces a 40% reduction in cerebral blood flow. Respiratory system, it is given to produce slight reduction in respiratory rate, and 3 mg IV has no significant effect on the tidal volume. Now the CVS, it produces vasodilatation with a decrease in BP because of moderate alpha adrenergic blockade. So it produces vasodilatation with a decrease in BP, and it possesses some antiarrhythmic effect like quinidine. Droperidol, it is used as an antiemetic, used along with opioids in epidural anesthesia, and it produces CNS depression, which is characterized by marked tranquility and cataleptic immobility. Coming to INNOVAR, combination of droperidol and fentanyl in the ratio of 5:1. So droperidol 5, fentanyl 1 is 2.5 mg per ml and 50 microgram per ml respectively. Lactic acid is added for adjustment of pH to 3.5 for optimum action. Consciousness returns within 3 to 5 minutes after stopping the drug. The combination is simply additive. So droperidol and fentanyl, the combination is simply additive. Pharmacology, the respiratory system produces respiratory depression, peripheral effects. There can be rigidity and central depression. Rigidity and central depression at the respiratory center, basically respiratory depression. Tidal volume and rate both are decreased. So there can be a decrease in BP, that is because of your droperidol. Heart rate increases because of fentanyl, so the increase in vagal tone, but there is no significant change in urine output. Uses initially it should be used as the first dose, followed by fentanyl. It produces hypnosis, anti-emesis, and sedation. Fentanyl produces analgesia, so that's how it's combined, because fentanyl produces the analgesia and the droperidol produces hypnosis, sedation, and anesthesia. So the side effects due to droperidol and due to fentanyl. Due to droperidol, there can be hypertension, prolonged sleep, extrapyramidal complications like dyskinesia, especially of the face, neck, and pharyngeal muscles, and there will be difficulty in swallowing, grimacing, spasms. And due to fentanyl, there will be muscle rigidity if a large dose of fentanyl is suddenly injected, and there will be respiratory depression. Now, DEXMEDETOMIDINE, it is a selective alpha-2 adrenergic agonist. It is a specific stereoisomer which is available as parenteral formulation. Metabolism is by dehydrogenation or glucuronidation. So on the CNS, alpha-2 agonist produces sedative and hypnotic effect by binding to alpha-2 receptors in local ceruleus. This is important. Okay, analgesic, so that is the sedative effect is on locus ceruleus. The analgesic is within the locus ceruleus and the spinal cord. So locus ceruleus is only sedation, and locus ceruleus and spinal cord is analgesics. There's an increase in PCO2 because it decreases the respiration and decreases the respiratory rate and tidal. So on the CVS, they decrease heart rate, systemic vascular resistance, and myocardial contractility. As a result, there's a decrease in kidney output. Uses are sedation, so it is used as a pre-medicant. It reduces other sedative anesthetic doses. It reduces the requirement of volatile anesthetics. It can be used during maintenance of anesthesia when muscle relaxation is not required. Non-benzodiazepine hypnotics, your ZOPICLONE and ZOPILDONE. So ZOPICLONE is a cyclopyranol hypnotic. It is basically an agonist at GABA which potentiates the action of GABA. It does not alter REM sleep. It prolongs the normal stages of sleep, so the patient gets up very, very fresh. So there is no hangover, doesn't develop hangover, withdrawal, or any dependence. So alteration in sleep pattern. So its T-half is 5 to 6 hours. Short term use for the treatment of insomnia. The negative point is the metallic and the bitter taste. Right? And of course, there can be impaired judgment. The patient's advised not to, etc. Zolpidem, it is a imidazopyridine which acts on the omega-1 subtype of benzodiazepine receptors. Again, it acts on benzodiazepine receptors. Hypnotic effect. Sleep latency is shortened and duration prolonged in insomniac, so sleep duration is prolonged. Lack of effect on sleep stages, so patient awakes fresh. There is minimal daytime sedation, and no tolerance of physical dependence because of this property. It is metabolized in the liver and has a short duration of action. The dose is 10 to 20 mg at bedtime. So that's it, guys. That concludes our class for today, which was on benzodiazepines. I have another class at 7:30 where I'll be taking the a quiz on uh, positioning. I have already covered that topic. It's an interesting quiz. Do log on and also use my code SASHA to avail that 10% discount. Thank you, guys. Have a good evening. See you all soon again.